My name's Anna Wilson. I'm the dementia lead nurse at South Tees. I'm going to focus on the acute side of things today. I know there's a lot of people from community settings here, but I think if we can work together on the recognition of delirium, we really can help things. We can help each other as clinicians, as carers and families. So I just want to start. This is NICE guidance, the National Institute for Healthcare Clinical Excellence. This is what, as the public, should expect when a patient's admitted to hospital. As you've heard from Ahmad, that doesn't always go to plan. So we know delirium is a change in a patient's mental state or consciousness. I'm not going to read all the way through this, but healthcare staff should think delirium whenever people are admitted to hospital or long-term care to improve early recognition. Delirium is prevented, if possible, in people identified to be at risk. Healthcare professionals diagnose delirium quickly and accurately. Delirium is treated first if it's hard to tell if a person has delirium or dementia or both. And delirium is treated urgently so that hospital stays are shorter and related problems such as falls, pressure ulcers, long hospital stays are reduced. It all sounds easy, doesn't it? Prevalence-wise, it's more common than you think, especially in patients with cognitive impairment. Thought to affect up to 50% of older people over 65. Generally speaking, the younger and fitter you are, the greater the insult it takes to trigger a delirium. So you can see there statistics for intensive care. Up to 87% of patients in critical care will suffer a delirium. But patients with a cognitive impairment, when admitted to hospital, are 5 times more likely to have a delirium. And it can also last a lot longer in patients who are old and frail. So I'm sorry this slide is a lot of words, but I'm just kind of going to talk around it. We've heard a very personal story there, and I'm sad to say that that isn't an isolated story about hospital management for patients with dementia and delirium. Sadly, it's quite heartbreaking sometimes when you read through some complaints, when you read through mortality reviews, incident reviews. We need to get better at this. But it's not easy. The recognition and management isn't easy, it's complicated. We might think, well, delirium's acute, dementia's chronic. It's black and white. As we've heard even from a brain expert, and I've had conversations with Ahmad, even as his own mum, sometimes he wasn't sure if there was delirium or if it was the progression of a disease. Sometimes it's very, very difficult, especially for us as acute clinicians, meeting a patient for the first time. Is this delirium? Is this dementia? Is this delirium on dementia? And that's where families, carers come in. We really depend on you to give us that collateral history so that we know. But it's very important for people like myself in roles like I'm in to promote that all our staff listen to carers, that we need to listen to carers, that we need to get this information to get better at this. Patients who develop delirium in hospital do have an increased risk of harm. There's data there related to the national audit of inpatient falls. 46% had signs of delirium on the 4AT before the fall that caused the fracture. Quite stark statistics. NHS England state the complications of delirium lead to additional healthcare costs estimated at around £13,000 per admission. We know that our local trust data, this is quite new that I've had oversight of this data. I'm getting quite obsessed with data because data is the way that within an organisation, within the NHS, you can potentially argue for more resources. But only recently I've had oversight of being able to see what our length of stay for our own patients are, because you know in research, you see the statistics, the length of stay increases for patients with delirium. But when you see your own data like that in black and white, or in this case in red, it's quite stark. So a patient admitted to James Cook Hospital without a delirium has an average length of stay of 2.3 days. A patient with a delirium, that increases to 18.2 days. That's over the past year. It's huge. Average trust length of stay for a patient with dementia, around 5 days, compared to a patient with dementia and delirium of 14 days. And there's a multitude of reasons that might contribute to that. Some of the complications associated with delirium. I'm sure Chris will go on to talk in his session that it gets difficult to then place patients out of hospital while they've still got an active delirium. Patients with delirium are sometimes difficult to care for. They can be resistive to care, and that makes challenging. Them getting diet and fluids into patients. It's the bread and butter of good nursing care, but it's not always easy. They're in a busy, unfamiliar environment with lots of unfamiliar noises, lots of unfamiliar people. I've got colleagues, I can see a few familiar faces from psychiatry liaison. I'm sure they would agree. We work closely together with the psychiatry liaison team. We have a therapeutic care team within the hospital as well to try and address some of these needs. But there's never enough, is there? There's never enough resources. There's never enough staff. And these patients need time. They need compassion. They need empathy. They need patience. And hospital systems, whether it's GP systems, hospital systems, NHS systems, not always set up to give patients the best journey through, and we'll probably all be familiar with that. But particular pressures in the NHS in the minute, patient flow, bed pressures, not enough care home beds, not enough hospital beds, long wait times in ED, ambulances stacked up. It's all about patient flow to move people on, to get people in. And this results in sometimes inappropriate movement of patients around the hospital at inappropriate times, which then prolongs the delirium. Again, I've just managed to get a database set up so we can look at that data as well with regards to how often patients are moved out of hours to try and do something about that. And ultimately, it's very distressing for patients and loved ones. I worked in critical care for a lot of years, and watching families see their relatives obviously being very unwell, but even as they improve and then the delirium kicking in, it's really, really, really distressing for patients and relatives. And sometimes patients would come back to follow-up clinics more traumatised by the delusions of the delirium than what landed them in critical care in the first place. So, from a national guidance point of view for us as acute care providers, NICE tells us we should be assessing patients with the following risk factors. There's multiple risk factors for delirium, but these are the ones that NICE state. Being over 65, having a cognitive impairment or dementia, having a hip fracture, having severe illness. So you can kind of see any person over 65 admitted to hospital is going to have at least two of those. We know that validated screening tools for delirium are better than clinical judgment alone. So all through the national guidance, we're advised to use a screening tool called the 4AT. Some of you will be familiar with it, maybe some of you aren't. A very simple screening tool. It's up there on the, I know it doesn't project very well, but it should only take 2 minutes. You can score for clearly abnormal. If you get a score of between 1 and 3, it suggests potentially a cognitive impairment. A score of 4 or more suggests delirium plus or minus a cognitive impairment. So it can guide us to think delirium. And this should be done on admission. So what have we tried to do to address the challenge at South Tees? The hospital acute trusts take part in something called the National Audit of Dementia, and one of the key parts of that audit looks at delirium screening, and it looks at nurse and care planning, and it looks at medical management plans. So from the National Audit of Dementia results, we were able to see areas that needed particular focus. Over recent years, the last 2 years in particular, we've started a switch over to digital records at South Tees. We're quite behind nationally with regards to that, actually. Again, it's money and resources. However, the rollout of the digital systems has now been quite rapid, but this gave an opportunity to build in systems to guide staff to do the right things at the right times, and have an electronic cognitive care plan with prompts for staff to do the right things at the right times. It also was an opportunity to roll out education alongside that, because there was a team of digital educators that could, so I went through all the cognitive assessments with them, and that teaching was rolled out trust-wide. It's enabled improvements in flagging and identification of patients with dementia and delirium by our digital systems. And just to say, critical care has specific guidelines and protocols for delirium management within critical care, and I won't go into details of that here. I deliver a lot of education within the trust, and I've worked with colleagues in psychiatry liaison and therapeutic care to promote that. We've had Krish has a giant inflatable brain, which we've had up in the atrium at James Cook for the last couple of years, and there's colleagues from psychiatry liaison there today with a stall in the atrium, educating both the staff and public. We brought in a carer's passport in support of John's campaign to enable carers to have open visiting. Our delirium guidelines have been updated, as has our dementia strategy. Collaborative working, there's a few teams listed on there, but I've already mentioned other teams as well. We have a therapeutic care team, we have a great older people's medicine team, and I have to say, I'm not stating here that all the problems are solved and care is perfect now at South Tees. But what I can hand on heart say is that there's a lot of good people there doing a lot of good things, and we want to make things better. We now have weekly multidisciplinary team meetings that we talk about vulnerable adults. This enables us to wrap the right care around the right patients. There's multiple professionals join that meeting. It happens every Wednesday. A lot of patients with delirium are discussed, some with dementia, some with learning disability, whatever that vulnerability is. But we have the nutrition teams attend, the tissue viability nurses, therapeutic care, myself, the learning disability lead, psychiatry liaison come. And what some of you who don't work in healthcare might not realise is that sometimes hospital systems don't talk to one another within the NHS either. For example, I can't see the mental health records with the mental health trust, and vice versa, unless the psychiatry liaison team within the trust are there. And this has been really helpful at this particular meeting. They can have their laptop and have access to those notes. That's really, really beneficial to clinical teams within the acute setting. So this is some of the pictures of the awareness raising events that we've raised That's Krish's brain. This is some of the teaching sessions. We do a little simulation, and we do some sensory deprivation stuff on the staff. Put goggles on them, put hospital sounds on their earphones. We do mean things like give them thickened fluids and not tell them that it's got thickener in. But the delirium pathway at South Tees now looks like this. All patients aged over 65 have a screening tool that's scheduled every 24 hours that pops up on our patient track system. And it's a single question in delirium. Are they different today? Are they more confused than normal? If this is answered positively, the system then prompts staff to complete the 4AT delirium screening tool. And if that's positive, it then prompts staff to complete a delirium time bundle. So going through, that basically goes through a lot of the potential underlying causes of a delirium. Pain, for example, infection, nutrition, constipation. It takes staff through it in a step-by-step process. We use something called the Forget-Me-Not card, which should be at every patient's bedside with the dementia, so their likes and dislikes are documented and any member of staff can pick that up. And that's a picture of our carer's passport. So some data comparison from data from the National Audit of Dementia done when we were on paper, comparing the post-introduction of the electronic patient records, and the data was collected in December 24. We were very, very poor on documented nurse and care plans on paper. There were only 18%, as you can see from the graphs. Delirium screening's improved as well. We're now up to 85% having a documented nurse and care plan. Now, I'm not saying just because there's a documented care plan that it's perfect, but we need to now look at more data with regards to has this improved outcomes for patients? Have we reduced things like falls and length of stay? We need to continue working with clinical and digital teams, keep going with the education and awareness raising, the collaborative work, and with events like this, with community colleagues and colleagues within the hospital trust as well. And it's going to, for me, be keep looking at data and taking it to the powers that be to please ask for more resources. But thank you for listening. I won't ask if there's any questions.
Come on, give it up for Anna, thank you.